Okay, so today's topic is to focus on the breast neoplasia, and we already talked about screening age, which there are some grades on about the 40-year-old, 45, I think is still the mainstream for exam purpose for complex or USMLE Step 1, and you would do mammogram screening. If the suspicious rating keeps going up, which is called the BI-RAD score, you would further perform either ultrasound, there's even MRI, but for exam purpose and even in real practice, it's just too expensive for insurance to cover, which don't usually show up, and it's not as diagnostic, so you would most likely proceed with biopsy. There are core needle biopsy, fine needle aspiration, which is an older technique, even like surgical biopsy, but those are only pretty invasive, performed in the setting where core needle biopsy is not diagnostic enough. So after you get the sample to do the pathology report, you would proceed with conclusion of either carcinoma in situ, carcinoma or benign condition, and a simplified way to categorize them, because we're going to focus on this part, the carcinomas. There's ductal carcinoma in situ, and I take the DC at invasive on top. That's the second condition, invasive ductal carcinoma, lobular carcinoma in situ, invasive lobular carcinoma. They're rarely the condition that is bilateral in terms of all the breast condition, even the benign one. Invasive lobular carcinoma is one of them. So I put BL, bilateral, of this condition plus the fibrocystic change. It's another condition, but it's not covered in the carcinoma category. And an oversimplified version of the anatomy of the breast is where there's the duct and the lobule. All these carcinoma conditions are coming from the epithelial cell line origin. And to tell them apart, either it is a in situ or invasive. In situ literally means that it's confined within the breast basement membrane. So imagine there's some fat tissue, there's the nucleus of some cells, and there's like lots of these cells. This is just to focus on one of them. And basement membrane will be surrounding the cancer cells. This is when these two guys are being called either lobular carcinoma in situ or ductal carcinoma in situ. And the treatment for ductal carcinoma in situ depends on something called a TNM. So TNM, tumor nodes metastases score. And it also depends on individual patient's condition, of course. And the rating goes from 1A, 1B, 2A, 2B, 3A, B, C, and 4. Don't ask me why this part 3 has a C and 4 is just by itself. But anyways, 8, there are total 8 scores. 8 being the not 8, 4 being the most worst prognosis. And this is where the metastases has go beyond the lymph node. And imagine this is our midline, and that's our right breast, left breast. And the most common sites of breast cancer metastases is always axillary lymph node. To treat ductal carcinoma in situ, you look at the TNM score, and doctors will make a decision. Either they want to do a mastectomy, which is a total breast removal, lumpectomy, which is partial removal, plus radiation, to be safe, right? Because if some cancer cell left behind, there's a chance of recurrence. And you will also do a sentinel node biopsy. Sentinel node biopsy is literally going through all the lymph nodes step by step. So let's say this step, I will probably go to axillary node first. I'm checking if the cancer cell is there. If it's there, then I will go to adjacent. If I can go lateral to pectoral lymph node, or I can go up, go back. So from that way, it can go from axillary lymph node, supra or infraclavicular lymph node, internal mammary, like here, parasternal lymph node. It can also go contralateral to the other side of the breast, which will be pretty late stage. Then metastases can happen. It can even invade other organ tissues like the lungs, the liver, bones, brain. That's pretty late stage. But anyways, coming back to our treatment, we've talked about mastectomy, lumpectomy. We talk about the importance of doing the lymph node biopsy. There's also pharmacologic treatment where there is because a lot of times breast cancer are estrogen receptor positive, so you could use a estrogen receptor targeting drug that's called tamoxifen as a chemoreceptor. Tamoxifen, interesting name, because it is a SERM, select estrogen receptor modulator. So I look at the drug name, MO modulator, and T, I use it to remember that it's for tits, so breast. Also maybe top, because it's on top, as an antagonist, which is important, estrogen antagonist, because it also acts as an agonist, not on the top part, on the lower part, where it's an antagonist to the bone and the endometrial, which is not something we want in this treatment, because we do want the antagonist of the breast part for treatment, even the bone part, because it does prevent osteoporosis, especially for postmenopausal women. But the endometrial part, for uterine, that is unwanted. So I use the U as unwanted as one of my mnemonic, uterine, for the not ideal side effects of tamoxifen. Other breast cancer could be progesterone receptor positive and even HER2 positive. There's a drug that's trastuzumab. If you say it fast enough, people won't catch it, right? Really bad at spelling drug names, but one of the famous mnemonic is trust her, so trust her as HER2 receptor modulator. And if you know the pharmacologic man, that's vincristine, vinblastine for peripheral neuropathy on the outside. And on the heart part, remember how there's like a D and there's like a T as like the septum of the heart, right? Looks like this specifically. The T part is trastuzumab because it gives you a adverse effect of cardiomyopathy. And the D part is doxorubicin, which is a cancer drug. I think Boards and Beyond mentioned that trastuzumab is somewhat reversible, so not as detrimental to doxorubicin, which is irreversible. So you can have patients stop this drug for a while and let them recover on the cardiomyocytes, but it really depends on patients' individual condition in real practice, and you can re-challenge them. So that's most of a pharmacologic treatment. It also depends on the tumor marker for treatment. There's also aromatase inhibitor, which it ends with ozol. So my first time looking at it, I almost thought it's like an azole antifungal drug, but it's not. Anastrozole is one of the commonly used one. There's also the one that's ANE, that's exmestane. And these drugs are only used for postmenopausal patients, I guess, because estrogen is too strong in premenopausal women. They just have too much, and it's really hard to like block the effect of estrogen with only an aromatase inhibitor. But postmenopausal women, they get their estrogen from peripheral fat tissue convert to estrogen, right? So it just works better. There are other stuff, lifestyle modification they can be aware of, like stop OCP. And there are some practice questions that I've seen as asking about OCP, what type of cancer does it prevent? And the answer, if I remember correctly, is it is not ideal for breast cancer. And there's not enough data to support, but I think it still is favorable to prevent endometrial cancer and ovarian cancer. I put a little question mark there, but at least it's not a risk factor. Compared to breast cancer, you do want to stop taking OCP in that stage. And of course, we always advise patients to stop smoking, do lifestyle modification, eat healthy, lose weight, because too much fat tissue does get converted to estrogen. Those are treatment for a ductal carcinoma in situ, and treatment will be similar for lobular carcinoma in situ. There's some feature you want to be buzzword aware of for invasive carcinoma in situ, because they don't have E-cadherin, something like that. And dirty medicine has a pretty good mnemonic where lost cadherin as lobular carcinoma in situ. So cadherin, lost carcinoma as the letters to remember. An invasive carcinoma in situ, they have like a single file. If you look at the pathology, I don't have pictures here, but if you look at it once, it does stick with you because it looks very specific. And it makes sense, right? We do things in medicine where it makes sense because of the loss of E-cadherin, which are a type of connective tissue. The cells just don't connect. They lined as like in a line. That's literally how it looks like on pathology picture. Invasive ductal carcinoma, most of the time it's on the lateral part. So if this is our breast divided to, that's medial, that's lateral, default quadrant, it'll most likely be on this quadrant. Just because it's more towards the axillary lymph node region, there's more breast tissue, which makes sense why, kind of, right? It rhymes with the axillary lymph node being at the same region. There is calcification you can see on ductal carcinoma, either in situ or invasive. So calcify for both of them when you do mammography. And lobular versus lobular is usually incidental findings. You wouldn't see that calcification. And you probably wouldn't jump right into a mastectomy for the patient. You would advise them to wait and see, come back every year for like a mammography. It does increase your risk to get a carcinoma, but not necessarily. You could wait and see. It does largely increase your risk for breast carcinoma. And it's very rare that breast cancer can have a negative tumor marker. In those cases, it's actually pretty bad. So you don't have, like, for on treatment perspective, you don't have like if you want to shoot at something, you don't have a target, right? That sounds to me just like a wild growth. And it usually happens to younger patients, less than 40-year-old, and it's just pretty wild. There's also BRCA1 and 2, those are famous too, for family inheritance of breast cancer. You want to do genetic counseling for the patient and the family as well. And it does increase risk for ovarian and breast cancer for male, and even pancreatic cancer for the last one.